Preeti is from Lucknow, and we didn't have an introductory slide, but I think she's the professor of endocrinology, HGPGI, Lucknow.
Yeah. So at the outset, I'd like to thank the organizing committee to make me a member of this academic program for everyone, by women, and conducted by women. Let's start with the scientific sessions. So talking about adolescent PCOS, we know that the classic features of polycystic ovary syndrome in adult women include chronic anovulation associated with relative infertility and polycystic ovarian morphology and clinical hyperandrogenism in the form of hirsutism, androgenic alopecia, acne. But to begin with, to take the diagnosis, only hirsutism is taken into account. Unfortunately, all other features of clinical hyperandrogenism are not taken into the diagnostic criteria. Worldwide, the prevalence of this condition is increasing, probably because the condition is being recognized more often, or we are diagnosing some cases which need not be polycystic ovary syndrome, which I'll talk about. We don't have much data on the community prevalence of polycystic ovary syndrome. The prevalence in young college girls from our own center was reported as 3.6%. This was a community college survey. This disease is heterogeneous in nature, and it impacts women in all stages of life, right from in utero till the geriatric population. The presentations and the issues concerning that particular subject are different. They change as age, the life stages go through from in utero till. As you can see, that what we are dealing with is an adolescent girl. For her, the cosmetic concerns, body image may be the predominant issue. When she becomes a young adult, the issues are about infertility, and if she gets pregnant, the issue concerning her are complications during pregnancy. And when she crosses the 5th or the 6th decade, metabolic problems as well as malignancies because of hyperestrogenemia become an issue. But for us doctors, probably the metabolic problems are the major issues, and we don't relate to the cosmetic issues with which the girl comes with. So these are a few important things which I would like to sort of allude to in the next 10 minutes or so. This is a complex disease where not one factor leads to the clinical manifestation. It is a conglomeration of factors in a susceptible woman with effects of changes during pregnancy or in utero exposure to androgens or energy restriction. All these come together to cause this phenotype. But the important thing which we know is that there is enough evidence to say that insulin resistance leading to hyperinsulinemia plays a definite role either in the causation of the disease, in the manifestation of the various phenotypes, but definitely it is has an important role to play in the long-term metabolic complications. So I, and maybe many other people, prefer to call it as a syndrome XX. Hyperinsulinemia, insulin resistance, what we called as syndrome X, but in a female it becomes like a syndrome XX. And the important thing for us to remember is that there is a transgenerational passage of this phenotype. So a mother, her daughter would be at a higher risk for PCO, and when in utero these babies are exposed to hyperandrogenism, there is some epigenetic changes which occur which cross over to the 3rd generation. So probably our focus should be to target these women who have PCO early on in their pregnancy so that this transgenerational progression into the subsequent generations is prevented and a major non-communicable disease is prevented. Why is diagnosis and prevention or treatment, appropriate treatment is important? This slide would tell you that practically all systems are affected in PCO. There are important ones which have the effect on the life expectancy, like increased risk of cardiovascular events. But when talking about adolescents, I think the body image issues, depression, anxiety may play an important role which should be addressed. So having laid the background that diagnosis of PCO is important, and early and a correct diagnosis should be made, and a fine balance between overdiagnosis and underdiagnosis has to be maintained. This I would explain in the subsequent slides. So if the diagnostic criteria for adult women have been laid down fairly well, although they have evolved, but they have been laid down fairly well, that if you have oligoanovulation, if you have PCOS morphology, or if you have hyperandrogenism, be it clinical or biochemical, any two out of these three, you would label the lady as having PCOS. But then what is the issue in diagnosing in adolescents? All the three people who introduced the adolescent endocrinology did say that diagnosis is difficult. It is difficult because the changes which occur during puberty are very similar to the presentation in PCOS. So whether it is a normal pubertal change or it is a disease, it's difficult to dissect out, but yes, we can still have a strong index of suspicion and manage the patient accordingly. We'll just see with an example in the next slide. A 13-and-a-half-year-old girl who had menarche at the age of 12 years, presented to the clinic. Generally, girls, if they have menstrual irregularity, they are likely to go to the OBGY. Very unlikely to come to the endocrinologist, maybe let alone a pediatric endocrinologist, very rarely, but maybe to a pediatrician. So this girl was taken by her mother to the OBGY clinic. Knowing that PCO diagnosis could be a possibility, the gynecologist ordered all these investigations and gave her a diagnosis of PCOS because she had a PCOD-like picture. She was overweight, had acanthosis, so had probably insulin resistance. This girl went back home, did a Google search. The mother came to know that she has high risk of infertility. All her morale went down. What will happen to my daughter 10 years from now, 12 years from now? The girl read about all the problems which can occur, and she her whole school life went upside down. She went into her shell and was very difficult to manage by the family and her friends. She went, similar kind, I've actually combined two cases together. The second case probably was similar, you could change the ages slightly, and she came to me as a pediatrician. I was a pediatric trainee at that time, and this was me who said that this was a normal event, go back home. She comes back 5 years later with significant hair growth, and the mother is very upset that you said this was normal pubertal changes, and now look at what has happened to my daughter. So this is a mistake which I made. So if she had gone to the endocrinologist, what would have happened? Would the things have been different? Doubtful. This was just a survey, and quite a few of you as well participated. I had just floated this survey into the Women in Endocrinology group as well, that if a girl comes with this history, what other ancillary parameters would you use to diagnose PCO in this kind of a girl? And majority, half of the responders were even OBGY people. It was circulated in their group as well. All the OBGY people said that they would use these criteria, and only 3 out of these 132 respondents said that we won't use any of these criteria to diagnose PCO in this girl. Similar results actually have been reported by Selma Wichel from a Virginia clinic. It's a teaching hospital clinic where there's an adolescent endocrinology center or a clinic, and she has also reported similar results, that people would use all these ancillary measures to diagnose, and only 28% people used tests to rule out the secondary causes of PCOS like non-classic CH, hyperprolactinemia, or androgen-producing tumor. So in a country like theirs, even in the US, people are still not aware, in spite of there being enough literature to say that we have to use these tests to rule out secondary causes of PCOS. So even if she had come to the endocrinologist, probably it would have been either way. So then we come to discuss that what are those pubertal changes, and how do we, in spite of not clear-cut diagnostic criteria, what do we do? So there is progressive maturation of the hypothalamic, pituitary, and gonadal axis. There is lack of a positive feedback at menarche and perimenarchal period, which leads to a decreased E2, and an LH surge is not there. So you have chronic anovulation in the perimenarchal period. Usually, by 90 to 95% of the girls start having a fairly regular cycle by 2 to 3 years of age. There is a very small percentage which takes about 5 years for their cycles to regularize. But even if the cycles are irregular, it is extremely uncommon to have more than 3 months period of amenorrhea in a normal girl. So if the cycle length is more than 90 days in a girl at the time of menarche, it should ring a bell. But overall, the clinical context is an indicator in which girl would you think that this oligomenorrhea or menstrual problem is an issue which should be investigated further. So within 1 year post-menarche, if the cycle is more than 90 days, within 1 to 3 years post-menarche, if the cycle length is less than 21, that means the girl has polymenorrhea, or the cycle length is more than 45 days, and beyond 3 years, it's just taken as adults, that more than 35 days of cycle length is taken as abnormal. Then the other two places where a girl can present with primary amenorrhea is, if the girl is 13 years or more, has a maternal history of PCOS or has hyperandrogenic features, then you should probably investigate. And if the girl has had thelaki for 2 to 3 years but hasn't had menarche, then she should be investigated. And primary amenorrhea in extremely rare situations can be a manifestation of PCOS. Coming to clinical hyperandrogenism, we know that these are terminal hair in 9 places which are androgen dependent, and you score these from 0 to 4 depending on the degree of terminal hair, the thickness and the area covered by these terminal hair. The only important thing to remember is that it should be differentiated from hypertrichosis, which is increased vellus hair and non-androgen dependent area. If you ask a girl what does she think about excessive hair growth, it's generally that the arms and legs hair growth is troubling to her, because those are obvious, those are visible to people. So they are a main concern, but unfortunately they are not androgen dependent, and no amount of anti-androgens are going to help you in treat those increased vellus hair growth. And as the menstrual cycles mature over a period of time, similarly the hirsutism score also increases. That prevalence of score of 1 to 2 of 7.3% at the perimenarchal period, the prevalence increases to nearly 1 in 3, or about 30% of girls more than 2 years post-menarche will have an upper lip score of 1 to 2. So again, hirsutism also is an evolving. So you really have to keep in mind that this could evolve over a period of time in an adolescent. So if a girl, same patient of ours who came at 13 years, had a score of 2, which was not clinically significant because we take a score more than 6 as hirsutism, but she has oligomenorrhea. So probably she does have something going on. So this kind of a patient should not be labeled as I labeled as normal pubertal event, or she would just have oligomenorrhea, forget about it. No. If only one component of the 2 is present, this girl should be labeled at risk of PCO and followed up yearly to see whether things settle down after 5 years or 6 years, or she gets a full-blown picture of PCOS. I would refrain from using ovarian ultrasound in at least the first 3 to 4 years after menarche, because the ovarian volume gradually increases post-menarche, settles by the age of 16, and then over a period of time it decreases by the 4th decade. In early menarchal period, perimenarchal period, you have something called as a multifollicular ovary. In PCOM, you have peripherally arranged follicles with central stroma thickened. In multifollicular ovary, you have follicles studded all over the ovary without the stroma being thickened. So that kind of a picture is very common in adolescents. So it will be very difficult to differentiate it from PCOM, and if you use that, you are very likely to falsely diagnose or make a false diagnosis of PCOS in such an adolescent. So the diagnosis for PCOS mandatory is to have hyperandrogenism and menstrual irregularity in any form. If only one component is present, identify that adolescent at risk and follow her up yearly till she normalizes or develops a full-blown picture. The management principles in adolescents and adults are nearly the same. The important thing to remember is that this is a condition where you need a detailed discussion with the family, because we are not actually treating the cause which is leading to the PCO morphology or PCOS phenotype. We are actually dealing with whatever problem the girl has come. So whatever actually hurts her the most, is it the irregular cycles, is it the acne, is it the hirsutism? You have to treat the symptom and not the disease. So this disease requires in-depth consultation with the patient and the family. The mother is worried about the cysts in the ovary and the infertility. You are worried about the metabolic problems. The girl is worried about her facial hirsutism. So there are three points of a triangle. They actually have to meet in a common ground, and the management has to occur. Lifestyle intervention is the cornerstone of therapy because it has a beneficial effect on the metabolic problems as well. And behavioral and psychological aspects and dealing with them, assessing them and dealing with them can never be overemphasized in this condition. Because in any other condition of lifestyle diseases, unless the girl herself understands or the girl cooperates with the treatment, it's not going to work. Belinda will talk about obesity. I think it's just the same, that unless the patient understands and you're able to involve her in her own care, nothing is going to work. No diet or no exercise specifically helps in a girl with PCO. And the best part is that even 5 to 10% weight loss improves the rate of ovulation and improves the menstrual irregularity. It doesn't work on the hirsutism, but at least the cycles become regular. And SMART, that's an acronym for the kind of goals which you should have for these girls. The goals should be small, achievable targets should be kept for the girls. So maybe a kilo, or the first thing should be that you don't gain weight for the next 4 to 6 weeks. That is a one positive step. And then after that, probably it could be made that you lose a certain amount of weight every month or every 4 weeks. The medical treatment is specific for menstrual cycles, hyperandrogenism. So for menstrual cycles, you can easily use progesterone withdrawal cyclical. You give the choice to the girl that if she decides to have a cycle every 4 weeks, every 6 weeks, and it works beautifully. We have girls who are on progesterone withdrawal for years on, and they're happy with it because they actually control their treatment. And it's very assuring. If you empower the girl with her own treatment, she is bound to follow your instructions. In hyperandrogenism, for mild hyperandrogenism, oral contraceptives work beautifully. But if the moderate to severe, you can add anti-androgens. Remember that if the girl is on anti-androgens, always use OCPs because you can never predict when she would get pregnant. And if it's a male fetus, then the anti-androgens would have an effect on the external genitalia of a male fetus. So always the anti-androgen should be combined with an OCP. And we tend to stop anti-androgen therapy at the time when they are getting married because again, we don't know when she would get pregnant. It's important to assess for various comorbidities. The glucose intolerance is usually done, but others are overlooked. And as I said, that psychosocial care or behavioral aspects or anxiety and depression is the most neglected aspect or the most neglected comorbidity in this population. Use of metformin. In addition to lifestyle measures, metformin can be considered in confirmed cases of, is considered in confirmed cases of PCO who have glucose intolerance. But it can always be considered in girls who are overweight and obese. It offers a benefit in the high-risk metabolic group, the group which is at highest risk to have metabolic issues. That means they are overweight, they have a strong family history of diabetes or CVD. But there's not enough evidence of benefit of metformin in hirsutism or regularizing cycles. And insulin estimation is not required to initiate treatment because there's no cutoff that this is the insulin resistance or insulin level beyond which you would say that metformin will be beneficial. Other options to use along with other than metformin could be GLP-1 analogs, bariatric surgery, inositols, and recently SGLT2 inhibitors also have been tried to be used in this population. So as I said, in any chronic disease or any lifestyle disease, unless the patient is physically and mentally well adjusted with well social adjustment, the treatment is not going to work. So you need to look at the, other than the biomedical health, you really need to have a good assessment of the psychological health, trying to see the presence of depression, anxiety, psychosocial dysfunction, eating disturbances, and body image issues. Unless they are addressed or something is done for these issues, the treatment is not going to work, because the girl is not in a right frame of mind to listen and accept what you are advising her. You want her full attention and cooperation for things to work. So all these issues have to be simultaneously addressed to have a beneficial effect. So Tejal and her group actually brought out a very nice paper in IJEM, Indian Journal of Endocrinology and Metabolism, guidelines that how should physicians or doctors counsel patients of PCOS, and what are the barriers for optimal care of women with PCOS. So the barriers actually transcend from the physician or the healthcare professional, the paramedical or the allied medical staff, and the family. So the problems are at every step. One, we are too busy. So we don't give enough time, or we don't actually consider that talking and counseling is a part of the therapy. We lack good communication skills. We are not trained. As a physician, when we are undergoing our training, we are not trained enough to be able to talk to patients. There is lack of good trained paramedical staff to provide lifestyle intervention, to monitor that is the lifestyle intervention therapy working, or is it being provided adequately. And then we have a lot of societal issues. Infertility is a big taboo in a family. So parents don't want to even acknowledge that their daughter has an issue which could lead to infertility. So probably the society also needs to accept that there are situations which can be worked out with. And then there are financial burdens, then there are issues about having good space for physical activity or infrastructure for physical activity in and around your surrounding where you live. And for adolescents, the academic or the school program doesn't give you time, place, or the infrastructure to inculcate physical activity in the routine school curriculum. There might be, say, 10 to 15% of schools which may be having a regular active physical education program, active sports program, but majority of the schools or the population doesn't have it. So these are major blocks for providing adequate care. So I would like to leave you with some important take-home messages, that if there is menstrual irregularity, consider PCOS in certain situations. You need to actually have a very fine balance between diagnosis and causing anxiety, like our patient had, or being naive and ignorant like me and actually leaving her like underdiagnosing. So at least identify at-risk individuals and keep them under your regular follow-up. Even if insulin resistance and hyperinsulinemia are a cause, but they have no role in diagnosis or monitoring treatment, you really need to assess for comorbidities. A healthy lifestyle measure has to be advocated to all. There is a definite role of pharmacotherapy in certain situations, and it is a good opportunity to address the health issues of the whole family, because parents and siblings of women with PCOS or girls with PCOS also have similar metabolic risks. And long-term follow-up for metabolic and reproductive issues are important in this cohort. Thank you.